Welcome to Variations 4, the neurological unit. In this video, we'll cover questions 11 to 17. The overall theme is head trauma and the Glasgow Coma Scale. So before we go any further, let's just look at Glasgow Coma Scale. Now, we are going to get into this in more of a hands-on fashion in your integrative nursing practice course. So we're not going to go through and explain each element, what each element means, just doing a really fast overview. And this is a slightly older version of the Glasgow Coma Scale, but it's still quite commonly used. We'll talk about some of the differences between this one and the newer one. Again, that'll be INP. So just a quick overview of the neurology of the Glasgow Coma Scale. And that's this. Right now, I'm going to say that chances are we're all going to be scoring a 15 on the Glasgow Coma Scale. Our eyes are staying open. Hopefully, I'm not putting you to sleep and your eyes are staying open, so you get a 4. You're oriented. Hopefully, you get a 5. And if I asked you to pick up a glass of water or raise your hand up or something, you could probably do that. A test of brain function as well in terms of all the circuits are connected, so to speak. You get a 6. Add those numbers up, you get 15. And any decline in Glasgow Coma Scale is potentially an early sign of neurological deficit or neurological decline. Okay, and that's all I want to say about the GCS for now. We'll get more into a practical side of it when we get to INP. So we'll come right back to that in a second when we look at questions 12 onwards. But first, question 11, just kind of taking a little side point here. What does the halo sign and the Stoker pad tell the nurse? What does this look like? Okay, well, there's your answer right there, a CSF leak. If you get someone with a head injury, they could be leaking CSF from their nose, from their ears. When we see patients on the surgical ward, if they've had a spinal, which again, if we haven't talked about yet in INP, we will, but there could have been a bit of cerebral spinal fluid leakage from there. You might see that on the Stoker pad. Theoretically speaking, and I say that because I've seen some CSF leakage on bandages and it doesn't look like this, but I haven't seen a lot. So my experience with CSF leaks is minimal, and that's probably a good thing. But theoretically, it's what they call a halo sign, which is something like this. So apparently it looks something like this, you know, a little bit of cerebral spinal fluid on the outside. You'll have the blood in the middle. Okay, so that we'll just leave that at that. That's more of an academic thing. I'm not sure how often you're going to see that on a Stoker pad, but you'll have to find other ways of assessing spinal sites and stuff, which if we haven't talked about in your surgical course, we will. Okay, so now moving on to question number 12. So before we talk about question 12 specifically, let's look at some rules, very general rules based on GCS, which you've been introduced to. So if someone has a mild brain injury, they'll score a GCS of 13 to 15. Okay, now there may have been a brief concussion, but generally their score will be pretty high, 13 to 15. They'll be monitored in the ER for a bit. They probably will not get any kind of CT scan. And if nothing changes in their presentation, they'll probably be sent home and ask that a family member monitors them overnight, calls them every hour, you know, make sure. Because what can happen is there might be a mild brain injury now, but there might be a slow bleed. And since we didn't do a CT scan, and even if we had done a CT scan, it might not have been detected. So we need to make sure the swelling's not, you know, carrying on, bleeding's not carrying on slowly, but they'll probably be sent home that day and a family will be asked to monitor them at night. Now, if someone comes to you, they emerge and has a GCS of 9 to 12, that's quite a bit lower. they're definitely going to get a CT scan. They're going to be kept overnight, and they're going to be observed by a nurse. They'll probably have a one-to-one, or very, very often the nurse will come in and check on them, wake them up, check their GCS, all that kind of stuff. They need to really watch out for up to 2 months. They could have, basically symptoms of neurological decline. And even then, even after the CT scan picks up what it picks up, the bleed could continue. It could get worse. So they have to be monitored at home, and people have to check in with them even after they're discharged. Severe brain injury, if you get a GCS of less than 8, you're going to the ICU, neuro ICU, for monitoring. Okay, that's a pretty serious way to be. You might need help breathing with intubation. You're going to need close neuro monitoring. You might need surgery. Okay. All right, so this is very, very general overview. Now, before we even, we'll talk about actually different kind of hematomas, but sometimes, I'll just say it right now, sometimes a slow bleed is more dangerous than a fast bleed because it doesn't get caught on the CT, and the patient goes home, and before you know it, they're getting much, much worse. Okay, let's just go back to the questions we're working on right now, though. And question number 12, now we ask us to apply that stuff. So Bob smacks his head. He scores a 13. What's going to happen to him? Well, we just talked about it. And there it is. A really important point here at the end of this answer key here is that any decline in GCS needs to be looked at very, very carefully. Okay, it could be considered an emergency. Depends on the context. And we'll talk more about that in INP too, because if you were really exhausted and were confused, or maybe you had you took some medication, some cough medication, some flu medication, some antibiotics, whatever, maybe you were a bit confused, your GCS would drop too. But without a history and context of head injury, I wouldn't be looking at that going, oh my gosh, I have to call the doctor. I'd be saying, well, your context and history tells me that, yeah, your GCS has dropped by 1 point, but I can kind of pinpoint what that is. And it's because you took this med and that med and this med. Go home, get some sleep, see you in the morning. But if we have the context of a patient who's had a head injury, then a 1 point drop or more in GCS can become an emergency because suddenly the bleeding might have picked up. Okay, 13, Jenny fell off her bike and scored that. What are we going to do for her? Well, that's the moderate one. That's the moderate brain injury. Okay, and you can look up what post-concussion symptoms are, but the bottom line is, I mean, any one of these people could have increased swelling or bleeding. And so, I mean, there's probably quite a big list there. Finally, that severe head injury, what's going on with 8 or less. Okay, and it's just kind of a summary of what we just talked about. So question 15 is really just asking you to apply, kind of put together everything we've said so far, like in a nutshell. Looking at the beginning of the first video in this unit up to now, like what's going on? Like if you look at a patient and the GCS is falling, how does that relate to ICP? Well, obviously ICP is going up. ICP is going up, and therefore CPP is going down. Perfusion to the brain is going down. Oxygen delivery to the brain cells is going down. And the patient's ability to keep eyes open, respond in an oriented fashion, and follow commands is decreasing. Their GCS is dropping. 16, review the head-to-toe collaborative map for head injuries. So this is map 8. Now, it shouldn't be a surprise that this map is not much different from the map we just looked at for ICP, because head injuries cause a rise in ICP. So you could basically put the two maps together. They're kind of the same thing. Talking about taking away a piece of the skull, making an incision into the skull, ectomy is taking a piece of the skull, plasty is putting it back together, going in there, removing excess fluid and swelling, draining liquids basically. Burr hole we already talked about. Diagnostic procedures. Talked about the stuff already. Talked about pupils. Whenever you have a head injury, we're going to get more into this later on in INP as well. Whenever you have a head injury, you got to think about cervical spinal health too. So you might need a CT of the cervical spine as well. As it says here, similar to ICP care above in the last concept map we looked at with the head to toe diagram. So that was 16. 17, our last question in this video, talking about brain tumors. Well, if you think about what a brain tumor is doing, whether it's malignant or benign, that's a different issue. The fact is, if you got a growth on the brain, it's pressing against tissues, and you're going to have focal deficits, and you're going to have a pressure, because tumors can cause injury, tumors cause pressure on tissues, tumors cause edema, swelling and edema. They can also block the drainage of CSF, and then you get hydrocephalus, which is a buildup of CSF on the brain. All of this is contributing to increasing ICP.